Hey. All right, welcome everybody. We'll give it a minute or two here just for anyone who needs to log in to give them the opportunity to do so. And then we will jump into a quick introduction and a little experience share and video chat with Dave Berg. Hey, Rennie Russell, long time no see, buddy.
How you doing, buddy?
Good. How's the Florida life?
Awesome. I'm in t-shirts, right?
Yeah, I know. I'll be down there next month. I'll look you up.
Come on down. We'll jump in the pool.
Definitely. What's up, Aaron?
Good. How are you doing?
Good. I got old forum mates, new forum mates. Rob, what's up?
Steve, how you feeling?
I'm doing all right. Better than yesterday, that's for sure.
Good.
So all downhill from here. That's good stuff. All right, so I want to respect everyone's time. So I know we have about 25 people registered, but there's a bunch that are going to be popping in here as we go. But in the interest of time, I'll just give a quick summary of how this all started and where we are, and then introduce Dave and let him take us on a journey. Every year I go through this process where I look at our healthcare and I'm amazed at how much more it's going to cost and how much less we're going to get for the increased rate. And it drives me crazy. I can't stand it. And I look at it every year and I want to do something good for my employees. I want them to feel cared for, and I want them to be in a place where they are just in a good, health protected, foundation. And that hasn't always felt that way. And this journey has made it really, really difficult. And I think employees are really stressed out by it as well. So I go on this process, and I go and I look through all the major carriers. I'm trying to find that magic vendor out there, that consultant who knows a secret that we haven't found yet. And they're just not there. And this year, when I went through this journey, I posted up in the EO Facebook page, and a couple of different people, Cameron Harold was the first, suggested that David Berg's company, Redirect Health, was taking a different approach. And through that different approach, there was a lot of benefit to be found. So he introduced the two of us, and David and I have had the opportunity to speak several times now. I've got to know several people on his team and his journey, and I really grew to appreciate what he's doing and how he's doing it, and the proactive manner in which he's going about healthcare, just care versus insurance. So I learned a lot through that process, but I'm not a good middleman. And a lot of you guys have reached out in between to say, hey, can you share what Dave shared with you and tell us what's going on? Is it real? Is it a good thing? Is it something we should look at too? I don't really know the answer to that, but I do know Dave does. And he has a lot of experience. So Dave's been in EO for a long time. What is it, 20-something years?
Yeah, 21, I think. YEO, back to the old.
Yeah, back to the Y days. Been in EO for a very long time. He's a physician by trade, and created this company as a second business. He might have more than two businesses, but this was not the initial business he was in EO for. Being a doctor, I believe was, right, Dave? Your health clinics?
Yeah, we had medical centers.
Yeah, so that was the original business, and this grew out of his own need. So I asked him, would you be willing to just jump on a call and do an experience share what you found, why you started this, what your approach is, how it's different, and just take us on your journey a little bit. Show us behind the curtain. And he was all about it. He's like, yeah, this is built for companies like ours. He'd love to share the experience that brought him to where he is today. So with that, I'll quit talking because I can talk for a long time and I don't like it. And Dave, it's all yours. Dave Berg, EO Arizona, and founder of Redirect Health.
Yeah. Hey guys. So thanks for having me on. And so I'm gonna go through this for about 30 minutes, maybe 40 minutes, and then I'm gonna let you guys take us to the top of the hour if you have questions and answers. I'm gonna do my absolute best not to make this a solicitation to Redirect Health. Though obviously I think we have the best answer in healthcare. If I didn't, I would change it to that best answer. So if any of you have a better answer, please tell me, and I promise you I will copy it within a month. But this is the best I can come up with right now. But my story starts back in the United States, back in 1995. My wife, who I met at the University of Toronto, she's a physician also. We moved down here because we were going to start our practice from Toronto to Phoenix, when I say down here. And we knew it'd be hard, but we hit some obstacles we didn't really know that we were going to hit. We knew it'd be hard though. One of the obstacles to fast track it was providing health care for our employees. And we didn't understand the difference between healthcare and health insurance. And back in those days, if you recall, deductibles were probably about $250. Copays are about $5, $10. And we discovered that in order for us to be able to afford healthcare for our employees that they could afford to use, we had to buy the healthcare with the lower deductibles, the lower copays in order to be able to do it. But deductibles weren't that hard anyway, weren't that high. But over the years, they started going up from $250 to $500 to $1,000 to $1,500. And when they got to $1,500, well, first off, none of my employees who were making $13, $14 an hour at that time could even afford it when it was $250, $500 deductibles. And what I also discovered is they couldn't even afford the time off work if they're making that kind of money. So I was really struggling with trying to figure out how to provide healthcare to my people. And coming out of Canada, I had a lot of misperceptions of how things were supposed to happen. But for instance, I thought that American holidays were the same as Canadian holidays. So I'm still paying for Boxing Day and Good Friday. Crazy thing, I just didn't know any better. So being that naive when we moved here, we were also that naive about healthcare and about health insurance. But we just learned how to do it. We learned the system, and we learned a lot of that. In order to be able to provide healthcare to employees, you had to start paying more and more money every year if you wanted to avoid the 20% increases. You guys all experience that too? Now, everybody looks so young. I'm the old guy who remembers the $500 deductibles, but they're at $5,000 now. So I don't know how much more, how much higher they can go. But being from Canada, we were used to the concept that we were going to take care of everybody in our business, that was somewhat of an obligation. It would never even struck us as being a normal thing that we would provide health insurance and we would subsidize enough of it so that only half of my company could afford it and the other half couldn't. That was just not a normal way of thinking in Canada. I'm not saying the Canadian healthcare system is better than the United States. It's got a ton of problems, and there's a ton of lack of access because the resources aren't there. But I will tell you that in Canada, people aren't afraid of the Canadian healthcare system, even though it's not as good as the American healthcare system like we experience in the United States. So bottom line is I had a lot of things I had to learn when I moved down here. And it took me about 10 years till sometime around 2006, 2007, where I thought, if I'm going to stay in business in healthcare, and I was in healthcare, we had primary care offices and surgery centers, I'm going to have to learn how to work this insurance thing. And my conclusion was that there was nobody looking out for my interests as a business owner. There was nobody looking out for my employees' interests as the users of healthcare. And I was in the business. And it was pretty obvious to me that it was going in the direction away from the purchaser and user. Everything it had been for 10 years. And there was never going to be anyone looking out for me. So I created my own system, bottom line, and I'll show it to you and I'll answer any questions about how you guys think about healthcare. But there are some key things if you know it, you wouldn't be any different than me in finding a solution to it. For instance, if you knew that you can get a baby for $3,000 or $30,000, you would probably dissect what it took to get it for $3,000 and just do that every time. That's all I did. And if you discovered that there were medications that could be $400 or $4 just by the way they were ordered and the place they're picked up, whether it's a grocery store or a major brand. I won't say major brands because I know this is recorded. And Sam, if I say any major brands, I'm going to ask you to edit them out because you know what will happen to me if this gets out. And it has happened to me, by the way. The major brands do not like you mentioning their names in even events like this. So we just discovered that there are these huge price differentials. And I don't mean just like 20% more expensive, but I mean 10 times more expensive, 100 times more expensive. And there were a ton of tricks tricks too strong a word. There were tons of it was not obvious where the higher prices were or how to get the lower prices. So what my wife and I did is we created a complete system back in 2007 that we deployed in 2008 for our own employees, and we only used it for ourselves. So we only used it for ourselves, and we found that we lowered our costs 20% that first year. And then next year, 15%, next year, 15, 20%, to the point now where we have healthcare costs less now than they were in 20 years ago. We spend less money per person on healthcare than we've ever spent on healthcare before, because we built a whole system around getting the people the care they need with the best prices. Or really, it's not even the best prices; it's just fair pricing. I don't really care if an MRI costs $250 or $300 or $400. I just don't want it to cost $4,000. I don't really care if a pill costs $4 or $10 or $12. I just don't want it to cost $400. So we just have created a system that helps people get the care they need and then helps them pay the right amount for it. And I had started doing this before I'd even started doing this. Was introduced to YEO by Elise Porter, who introduced me to all the, if anyone's old here, you remember the old names of Vern Harnish, Phil Carroll, Neil Balter. I mean, there's so many of them. So I learned a lot about just applying an entrepreneurial way of thinking and an engineering way of thinking to the healthcare system back from my early YEO days. And then when I figured this out for myself in 2008 was the first year I deployed it. If you recall, the recession of 2000, late 8 and 9 started happening. And as people started laying people off, the people who were still working were getting 30% bumps in insurance costs. So I probably had 15 friends in YEO that were struggling with affording health insurance. And I just shared with them what I was doing. And we did it one after another, and it worked for every single one of them. This is back in 2009 when the recession was happening. And I remember I told a few of my friends, okay, I'll do it for you, but you can't tell anyone. And then I started having people come to me and say, hey, Neil Balter said that I wasn't supposed to tell you, I wasn't supposed to tell you that he recommended me, but I hear you're doing something pretty cool. So there was no way to keep YEO guys quiet. And I started getting in a little bit of trouble, and I was spending a lot of time with my YEO friends trying to figure this beast out of healthcare. And I had my wife and a business partner at the time come to me and just say, hey, you got to start charging your friends, or you got to stop doing it. So we created a company called Redirect Health in 2013. And our costs today are the best in the country that I'm aware of, benefit for benefit. But the reason is because we've taken such a systematic approach to eliminating unnecessary activity and unnecessary spending in healthcare. So we give people the care they need, but we eliminate the activity and spending. When I say activity, I'm being very intentional with that word. It's meaning I want to eliminate the drive to the doctor's office if a phone call can work. I want to eliminate the missing work, which is going to affect their paycheck, if we can do something over the phone, or we can do something over text, or we can do something after hours. So we just took a very pragmatic, systematic, strategic approach to it, and it worked really well. And like I said, I had a lot of friends in YEO who wanted me to help them, all my forum mates, obviously. But so I created a company. And you think any of my friends would, because I wanted to charge my friends. That was the only reason I created a company, is so I can charge my friends. And you think any of my friends in YEO would pay me a dime? Nope, not a dime. Which was good for me, because I had to learn how to actually market what I was doing to third-party people who are arm's length. And I'm going to fast track now. We are in all 50 states. We have over 1,000 businesses, all small businesses. I do not know how many EO companies. We don't keep track of that. I probably should have, but this was never intended to be commercialized when we first did it. It was just intended to be for my company and for my friends' companies. Almost all of them were in YEO at that time. And then we were just going to do it for Arizona. Then we were going to just do it for Arizona companies that were had employees outside of Arizona. Now we're in all 50 states, including Alaska and Hawaii. And it's a blast. It's the same principles today that applied in 2008 when we started this. Of just making sure we first discover what the care is people need, and make sure we navigate them to the places they need with the timing they need it. It's just really good medicine. And really good medicine actually costs less money. And I'm going to show you a graphic, just 2 slides, that'll make it make sense to you why more medicine in the right places actually saves a ton of money. And that's really the thing I want to share with you guys today, so you can be more educated consumers of healthcare. So why does this matter for a small business? If you look at just the average wages of American workers, adult workers in America, 2015 Social Security information, so it's a little dated, 6 years, but it hasn't gone up much. It's 51% of people make $15 an hour or less. 51% of American workers make $15 an hour or less. Now, let's what does that mean if they make $15 an hour or less? Gosh, it's probably if they make $25 an hour or less. But I promise you, those people who make $15 an hour or less, they don't have any money left over for food and shelter and transportation, and daycare now has been a big challenge. The stuff that's happening with COVID right now is really disproportionately hurt moms with daycare, and we're seeing a lot of moms being taken out of the workforce because of it. But there's no extra money is my point. And that 51% who make under $15 an hour, I want to take it to a more relevant stat for us all in this call. If you take out government jobs and you take out big corporation jobs, what do you think and all that's left is small businesses, our businesses, what percentage of our people make, let's say, over $20 an hour? Anybody have a guess? Nationwide, it's 10%. So we can guess we might have some people in our company that are making more money, or we might be in an industry where it's more white collar. Like we don't see this in accounting firms or law or engineering firms or sometimes real estate firms. But when you're in construction and retail and new startups, it's assisted living, nobody's got extra money left over. And there is no product that's out there right now with the big carriers, the Uniteds, the Aetnas, the Blue Crosses. They're all great companies, but they don't have a product for our businesses and our people, especially not if we want to take care of 100% of our business. If we want to take care of just that 10%, easy. If we want to subsidize it and take care of another 40%, it's a pain in the butt, but we can do it. But there's really no way for us to take care of the last 50% in America today. And if you've got a way, let me know. Like I said, I will copy it fast, because I only built this because I couldn't find somebody else who was doing it and who would sell it to me. So it matters because small businesses, if we believe small businesses are important to America, we've got to figure this one out. If we think big corporations and government jobs are where American jobs should be, then maybe we don't. I personally think that I'm biased, just like all you are, I'm sure. EO companies, we've got to figure this out because we don't have a healthcare system that's designed for us. That's my conclusion anyway. So let me tell you in a nutshell what redirect health is, and then I'm going to try to make it make sense to you. But really, what I want to answer is hey, this sounds like bull. This is too good to be true. I want to answer that question. I've done this enough that I've learned that if I don't answer the question, if I don't give the answer to the secret sauce, that people are they somewhat are disillusioned by it. But at the same time, I'll show you how it's done, and then it's really just an execution game. Some of which you can do yourself too with your existing health plan if you happen to be in a company that's lucky enough to have lots of margin or higher paid employees who can afford the out-of-pocket. So in a nutshell, we created a mutual insurance company and a third-party administrator so that it's a combination and allows us to move the money really, really fast, all within the same bank account. And you need licenses to do that. We have licenses in all 50 states that allow us to do it. That's probably the hard part of what we did, and I'm going to start with it first, is we created a mutual insurance company with a third-party administrator allows us to move the money fast. That means pay doctors fast, just move the money so it doesn't get stuck and people don't get frustrated with it. Because when the money gets stuck, people get scared and they start making irrational decisions around using ERs and second opinions and et cetera. So moving the money fast gives a lot of confidence, and it's a it's always been a mandatory part of this system that we built working well, is we have to move the money fast and with certainty. And let me define mutual insurance company. I'm realizing I might not define that. A mutual insurance company is an insurance company that does not distribute profits. There are the policyholders are the owners. So it's for we create an association, and it's a club, if you will, and the mutual insurance company is for the benefit of the association, the business owners that are part of it, meaning that any money that's left over stays in the mutual insurance company for the benefit of those association members. And we've chosen not to distribute it because we want to use it in the future to keep the cost from going up in the future, but also to pay claims in the future. Make sense? Mutual insurance companies for the benefit. I didn't make it up. I just hired a very expensive consultant to tell me about what a mutual insurance, that I should use it, and then build it for me. And I built it so that it interfaces really well with the part that I really care about. Is we also have medical licenses in all 50 states. So we're able to do medicine and to collaborate with other doctors and hospitals in all 50 states. And we're able to do it in a proactive manner, meaning collect data from people before they have a need and understand where they're likely to spend money. We want to prioritize not just clinically, but financially for the benefit of the mutual insurance company, so that people get the care they need and they pay the right amount. That is the formula for keeping costs sustainable. And I used to think that cost of healthcare in the United States was extremely expensive. I realize now it's the cost of the middlemen who are running it that are extremely expensive. The cost of healthcare is no more expensive today from what I'm experiencing than it was 10 years ago, 20 years ago. But all the things get added to it, the complexities get added to it, are a lot more expensive today. So in a nutshell, we create a mutual insurance company and a third-party administrator to move money fast. And we have medical licenses in all 50 states. We got about 250 employees. Half of them at least have to be clinical. So we can get in front of claims before they happen, provide the care before the claim happens, make sure it happens at the right amount, the right place, with the right timing. And by that combination that I just mentioned allows us to be so strategic with respect to eliminating the unnecessary activity in healthcare. That could be paperwork. It could be an MRI. It could be a surgery. It could be a second prescription when you only need one. And so we apply a lot of strategy. It could even mean taking a pill and you need 10 milligrams of something. It could mean buying 20 milligrams and cutting them in half because it's a tenth the cost. So we know how to maneuver around the healthcare. So it's not for everybody. Not for everybody. Some people don't even want to think about it. They just want to go spend money. But that is a formula for 10%, 20%, 30% increases every year. So this is a club for people who want to create a sustainable answer. And that means that we do things like that. We figure out what people need and what's the best way to get the right cost for that thing that they need. And when I say strategic, it's also very collaborative. So there's a lot of collaboration between us and doctors in the community in all 50 states. Lots of collaboration between us and the hospital systems. Lots of collaboration between us and the HR managers, the owners. Lots of collaboration between the owners and the HR managers and their employees. Another key thing that we have found really ramped up the sustainability of and predictability of what we're doing is we help the business owners understand their role, and the HR managers and the CFO or controllers understand their roles. And the very best team I've seen is when you've got the business owner or CEO's job is to determine strategy of how they want to have their healthcare plan affect their recruiting advantages, their retention advantages, their workers' comp costs. There's a lot of strategy involved in using the healthcare when you get the cost so low. When you put free healthcare in a job ad, it is a strategic advantage. And my experience has been that CFOs and HR people are not that excited by that strategy, but CEOs are. But at the same time, CEOs don't tend to be very excited about communicating the health plan to their people and helping their people, collaborating with their people as much as HR people. And the CFO or controllers or accountants are much better at understanding the total cost of things and making sure the company can afford it, but also helping the company take advantage of sustained pricing the next year. One of the problems I always had is if I could afford healthcare this year and I was making promises to my people this year, or I hired somebody this year and they expected my health plan, I didn't know what I was going to have to pay next year. So because we have a mutual now, we have this system, it's much, much easier for me and our clients to be able to know what things are going to cost next year. So that's us in a nutshell. Let me pause a bit and see if there's any questions, and then I'm gonna just show you the secret sauce in 2 slides that will, I think it'll make it all a little more believable for you that anybody can get healthcare costs where they should be. When I say anybody, it's a lot of work, but if a kid that escapes a strip mall out of Scarborough, Ontario can figure it out, I'm sure that any American entrepreneur can figure it out. Are there any questions? I see a couple of chats there.
It makes me, this is Rob Levon from Connecticut EO. It makes me think of like a fiduciary financial advisor who is like fee-based only versus someone who's commission-based. You know, would you compare like your model to that in a way, as in like you know, get the cost down as low as possible, but like, I guess, how are you winning in this regard?
Yeah, so we created a membership business.
Mm-hmm.
Yeah, so all we get is, think of the Costco. Costco, they say they don't make any margins on the stuff. Who knows if they really do? But the membership is where they make their money.
Yeah.
So we make our money on the membership. We don't make any money out of the mutual insurance company. If we price it right, we don't make any money out of the third-party administrator. I think I'm losing a little bit. I probably have to raise the rate, but it's just moving money internally a little bit. It's not, I don't need to raise it to the customer. But our goal is to only make money in one place,
Mm-hmm.
which is the membership.
Hmm.
So us running the association, that's where we make the money. And it's to my advantage too, Rob, because it's easier. It's a simpler model.
Mm.
I'd much rather have all that other complexity outside of the core business model.
Yep. I like that because then it allows you to be transparent. And then the other question I had is, are people making all of these decisions as to, you know, oh, we can save if you get a 20 milligram pill versus a 10 milligram pill, or have you kind of built a series of logic into software that's helping make these decisions for you?
Yeah, both, and increasingly, but there's still people, there's a lot of human judgment, and it needs to be. There's a lot of people involved on all sides.
Mm-hmm.
Our side, your side, the doctors, work with tens of thousands of doctors and hospitals and all over the country. Nobody's predictable. So
Mm-hmm.
to actually put an algorithm in place, and I really mean it when I say it's not about getting the best price, not about getting the lowest price. That takes too long and it's not worth it. But if I know that, but I look at data a lot, or my team does, and we have process for looking at the data and algorithms for looking at the data. And I'll give you one that we run all the time, and it has saved millions of dollars, literally millions of dollars, on little things that happen really often. So statins, just a common pill for cholesterol, high blood pressure. It's a common thing. There's generic versions of it. They've been around forever. They're safe. You don't need the really expensive ones. Most people don't, unless it's really, really bad. But only a very small percentage of people need the high brand name things that are quite expensive. But let's just talk about the generic stuff. If you go to a major brand, pharmacy brand, drugstore brand, it's not uncommon for that statin to cost $180 a month. If you take that exact same pill, prescribed the exact same way by the exact same doctor, made in the exact same factory, and you go to Safeway, it's $5.69. So think about that. It's about $174 savings, but it's monthly recurring savings, which means 100% of it goes to the bottom line of the mutual insurance company. It's not like revenue where only a portion gets there. It's monthly recurring savings. Now, monthly recurring revenue, which is also awesome, but monthly, which is our membership business, but it's monthly recurring savings that goes right to the benefit of the mutual insurance company, our shareholders. So now if that person, that employee, is a member for 5 years, That's $175 a month recurring savings for the mutual for that person every month for 5 years. It starts to add up. You do that for 1,000 people, 14,000 people, 20,000 people. It starts to add up into some real serious dollars. And those are the dollars that we use to keep the price down. That's the biggest savings we have, is that monthly recurring savings of little tiny things. And that's where we need the algorithms. That's where we need to be for the awareness, for the computer to point out, hey, there's an opportunity here. But the truth is, if we don't hit that opportunity this month, who cares? We can get it next month. We miss it then, who cares? We can get it the next month. We can get it. That's what the majority of the savings is, and algorithms are very important, and us looking at the data is very important. But there's another place that's really important too, and but important for other reasons. Let's say somebody has a new cancer diagnosis. We know that done right, that cancer, the cost of care might be $30,000, $40,000. Done wrong, it might be $200,000, $300,000. That's when we don't want to miss this month. Not only because it's a more serious condition, but we're going to free up. But if we miss the mark at the beginning, we could set up where we just cost the plan $100,000 because we were a month late on something. And when somebody gets cancer, remember, it's not just one treatment. It's 200 things that are put together into a treatment program where nobody knows at the beginning exactly what pathway is going to happen, the healthcare journey that's going to happen. All right, any other quick questions? I want to show you how we think about the healthcare journey.
So Dave, there is one follow-up question to that chain in the chat. David Eben's asking, what if the doctor feels you should not use the generic drug? Can the employee still get a savings?
Somewhat, but the difference might be we'll get them to $300 versus $500 versus we'll get them from 180 to 5. And remember now, the more money somebody makes, the less they might care about that. People on this call, I don't know, you might not care if you pay 180 or 5. I do, but I care more. I don't care about it one time as much as I care about it thousands of times. And I now that I know differently, I just don't like feeling I was taken advantage of because of a lack of knowledge. So there's a psychological part of it, but I promise you, I have spent $180 for things I knew should cost $5 for the convenience myself, many times. I would tell you that my employee that makes $15 an hour, they've never done that. And if I don't have a way to help them get it for $5, they're not going to spend $180, and they're just going to miss the care. The cost of care and the confusion and complexity around cost is the number one reason in your companies and my company and America probably of why people don't get the right healthcare they need. It's the fear of the cost. And even if something only costs $30, but they perceive it costs $300, they're going to act as if it's a $300 cost, even though it's only 30 or 3. That makes sense, huh? So a big problem that we solve in a collaborative and strategic way is we have to get in front of fear. There was another question here about, no, I think I just answered it. So addressing people's fear is a big part of keeping the cost down and getting people the care they need. And if a doctor says, hey, you need the brand name drug and it's $500 and it would create too much fear in somebody, even though we know the generic is just as good. Matter of fact, made in the same factory. If you take the 2 pills next to each other, they have the same numbers on them. The only difference is the box. There are doctors that say, I just don't trust the generics. And they'll throw something out there about the generic drug could be made in any one of 10 factories versus the brand name is made in one factory. And I guess there's some legitimacy to that for some things, but for your basic thyroid medication, your cholesterol medication, high blood pressure medication, these things have been around so long. In theory, that fear makes sense, but that fear is really expensive. And fear, there is a whole economy in fear in healthcare. That's what drives healthcare costs, is fear. And some doctors buy into it, others don't. But let me do this. I want to show you just how we think about the healthcare journey. And the goal here is to get you guys a little bit smarter, but not so much that I bore you. And you feel free to give me lots of advice if I went too far and I get too excited about it and I bore you. Okay, by the way, you can, if you go to redirecthealth.com, ending the fight, we'll send you a book, and you can get the free ebook too if you want. But at very least, listen to the 3-minute message. Okay, so I'm going to go fast. I went through some of this stuff. Everything points to we have to make healthcare simpler and affordable. But here's the key word: everyone in the company. So everything we do with the mutual, the third-party administrator, is all about how do we make it simpler. The membership fee as a way of us making money is one way to make it simpler. It also helps with affordability. Us eliminating unnecessary activity and unnecessary spend, that's how the biggest move for making it affordable. If we do both those things, then it's suitable for both people. Let me skip some slides here because I don't want to go through all of them, but I'm going to go fast. Okay. Here's the traditional healthcare journey. None of this should be new to you, but there's a little thing at the end that you probably don't know. It usually starts with primary care physicians as the gatekeeper leading the way. If it doesn't, it should. If you have a health plan today, you should have it starting with primary care doctors. It is not wise to have a health plan in American business today that allows people to go to specialists directly. I would highly recommend against it. There are some very expensive plans that allow it. I wouldn't allow it in my company because I know where that can get off the tracks very easily. But every primary care doctor, if they want to be successful, they have to have easy access to the everyday routine care. They have to have access to labs, generic prescriptions, x-ray. There's got to be a way to take care of aches and pains, back pain, knee pain, hip pain. If you don't, your plan is going to direct people right to the orthopedic surgeons. And there are a lot of surgeries, though it's not quite fair to say that unnecessary. There are a lot of surgeries that could wait for 5 years that happen today. And I'd much rather, if I was going to spend money, spend it 5 years from now than spend it today. And a lot of people get better without the surgery too if you give them 5 years. But if the surgery is needed, let's do it today. But let's make sure it's needed. So this is where healthcare starts. Primary care, they using routine services every single day. This is where the high volume stuff is. A little less volume is when things get a little bit more severe or a little more significant. Doctors, primary care doctors, have to be able to communicate with the specialist community. They have to be able to order MRIs. They have to work with surgeons, manage hospital a little bit. But this isn't all of it. Because in a very, very infrequent amount of time, I'm going to say less than 1/10 of 1%, people are going to need dialysis, organ transplant, skilled nursing, or they're going to need specialty drugs, those drugs that cost $100,000 a year. They're very expensive things, but the frequency of needing them is very low. Rarely does a primary care doctor manage these things. It's usually the specialist. Okay, that all makes sense. That journey makes sense, right? That shouldn't be a surprise to anybody. But this is the part that probably was eye-opening to me anyway, is this is where the money is spent. This is where the money is made. This is where the profit is made. There's a reason why hospitals in America now are all publicly traded. There's a reason why drug companies are all publicly traded. Even dialysis companies now are publicly traded, and they're consolidated into one. This is where the money is. So what we decided to do, what we set out to do, was to change the money in this journey. And we started here. We started by tripling the amount of money being spent on primary care. It absolutely sounded ridiculous when we first decided to do it also. But when I realized how much money was being spent, I knew that primary care had the ability to prevent some of it. There was lots of money to pay for it. And not only did we increase the primary care by triple, but we also increased the services they order frequently and in high volume by 50%. The money spent on it. When we did that, we just took it from the higher, where the money was already being spent at the end of the journey. But what happened is it freed up a ton of money. It freed up a lot of money that never had to be spent by the employer. So this is what we set out to do. Kind of makes sense, doesn't it? Now the question could be, well, how did you do it? I get that. But if you could do this, isn't that what anybody would do? If you knew where the money would. When I started writing my own checks, guys, game on. It was a new game. When I started writing my own checks, when I created a system where I could see what that a baby here costs $3,000, a baby there costs $30,000, and I started managing it for my own employees, what happened is they loved it because now there was money left over to actually pay for the care, so they didn't have to pay. Okay, so let me show you what we did in order to redirect these dollars to triple fund primary care and 50% pay for the everyday care, or not overpay. Increase the budget for the everyday care also, freeing up a lot of money for the employer. So we wanted a better, faster system and one that had the right spend, not the lowest spend, but the right spend. And it still started with the primary care and the services they needed. And we knew we had to have specialists and MRIs in hospitals, and people were going to need dialysis. So we didn't skimp on these things. We make sure people are going to get these things. But we want to support primary care to keep the money at the front end of the journey. Not all the money, but some of the money, that little bit. We want to triple the primary care. We want to 50% more the everyday care. So it started with using data and creating an electronic medical record on every one of my employees and now our members' employees before they even have a need, before the plan year even starts. And we're going to reach out to people in a clinically prioritized, but also financially prioritized way. Meaning if we see a monthly recurring savings opportunity, we're going to jump on it as soon as we have the resources to do it. But if we see somebody going through cancer care, we're going to redirect the resources there first. Because we can always get the monthly recurring savings later on that statin as an example. But we want to hit the ground running fast using the clinical data. And I'd mentioned earlier, I went fast on it, that we have medical licenses in all 50 states, which allows us to get in front of the claim before it even happens. The healthcare industry today uses big data to measure claim data to determine how to charge more and how to get more claims. We use clinical data to figure out how to avoid the claim. What does that look like in real life? We want to know somebody's a diabetic. We want to know that they make $15 an hour. We want to know that they were in an emergency room last year because they ran out of insulin. And we want to put that data together and go, hey, let's really nurture this family until we make sure they're never going to run out of insulin. That'd be an example of population health using clinical data in order. It's just smart. It's when I just described is what every medical doctor does for their own family already. Doctors don't have doctor's appointments even 1/10 as much as the general public because we know how to do this. I just created a system with a membership model that does what every doctor already does. Every mom with a medical degree already does for her own family. And I joke with my wife, who is that medical doctor with mom with a medical degree, and I joke that I just did biomimicry, like tree frogs and suction cups. She doesn't laugh either. But the next stage is we want to be available to people virtually 24/7. Because these people work, and if they miss an hour of work, that just made rent a little bit harder. Rent's already hard every month. If they have to miss half a day of work because a kid's sick or go see a doctor, that could be the reason why they don't come see a doctor, and then they let us get so bad they're in an emergency room later. But we want to be available virtually first, 24/7, English and Spanish. Matter of fact, with the technology now, I don't know there's a language we can help people in. And I know that we've done Russian and Vietnamese before, so I can't imagine, and people who are deaf. So I can't imagine there's any language we can't help at this point. That was different 10 years ago, but now technology allows us to do more than we could before. But we don't want to just, like a normal teledoc service, tell somebody, yeah, we're worried about that, go see your doctor in the morning, or go to the emergency room or go to the urgent care. because we have all the records in front of us, because we collected that clinical data, we can get a lot more involved in what our recommendations are. And because we're available 24/7 through our app, and it's bi-directional, it's continuous, we can do things that if I don't know I can talk to you tomorrow, or I can't talk to you in 5 minutes, or you can't call me back in 5 minutes, I'm gonna make a totally different decision in the middle of the night than if you sprain your ankle in the middle of the night, unless there's a bone sticking out, I'm not telling you to go to the emergency room. I'm telling you to put ice on it, wrap it, raise it, take some Tylenol, and call me back in 5 minutes if it gets worse. Otherwise, in the morning, let's get a $28 x-ray. And then let me look at the x-ray, and then we'll make some new decisions tomorrow morning. So this is we call it virtual first primary care, in that it's not teledoc. We're not trying to replace a service. We want everything to start here. And our recommendation might be, hey, let's get you in with the cardiologist. Let's get you to the urgent care. Let's get you to the emergency room right now. But we're going to call the emergency room doctor before you get there. That's an important part of this, because when it does get advanced and we need to do a little bit more, managing that referral and that navigation so we can predetermine the service costs, and so that we can get doctors talking to doctors, that is a tremendous, tremendous advantage for eliminating the unnecessary spending in the hospitals, etc. Again, I hope this just makes sense. And it's just, your questions are more just about, is this really possible to do it? But I hope it makes sense, because what I'm describing to you is what every single mother with a medical degree already does for her own family. And of course, when things are getting to the expensive part of the journey, the healthcare journey, we want to look for alternative funding methods. There are many of our employees that qualify for emergency Medicaid or Medicare disability, and we want to make sure we tap into those things they qualify for. And every drug out there that's really expensive has free services, free medications that we can go get. Remember, it's not about trying to avoid giving people the care they need or avoid paying for it. We want to protect that mutual insurance company so we can provide care to people next year and the year after and the year after. And so we can provide care to people, all the people in your company, everyone in the company. And we want to manage. So we want to, if somebody qualifies for something, we're going to get it. We're going to get it, and we're going to protect the mutual. We're going to protect the association, the club, if you will. And when somebody, the last point there, I've got insurance management. If somebody's got need of significant amounts of care, and their plan year starts in January, it is our responsibility to help them manage the money, because there are some out of pockets. And I see it all the time where people get care in December and they have one deductible that applies, and then they get care in January and it's another deductible applies. When all the time we could have delayed December to January, or we could have sped up January into December. So having the medical personnel with all the data in front of it, it gives a huge advantages of making sure we can time the services so we can maximize the use of the insurance. The last thing I want to do, if somebody's got a $2,000 deductible, is turn it into $4,000 because some services happen in December, some happen in January. It's just not right to do. So again, the goal is to move everything to this end of the journey. And of course, we got to get the benefit design right. I'm gonna jump off of that. I'm not going to go into all the benefit design things. You can see it on our website, and you can go. Our benefit design is there for anybody. And I've had some people tell me that they built their own benefit design and they made their own plans better just by using some of the things that we've got in there. But the key thing is make it easy for primary care. Get rid of the copays at the early part of the journey. Get rid of the user fees for primary care and labs and generic medications, x-ray, chiropractors. Like, don't make people pay a lot of money there. And especially if you're a big enough company, you can afford to get a case manager or an RN. They can help manage some of this with your employees. So let me jump off of this, and I think we got 10 minutes left for questions.
All right, Dave, we got one question in there. How is this different from a faith-based health share program like Liberty or Athena?
Okay, so two ways it's different. One, that those are medical cost shares. This is a mutual insurance company. So and the biggest difference is the regulation. So there's reserves, there's licensing. I mean, you've got to hit certain reserve targets. There's actuarial things that go into play for a mutual insurance company. And a medical cost share, it's a lot looser. So you could argue that one's safer than the other. I don't know. I don't know that it is. I like medical cost shares. I like the faith-based ones. The other, so it's just more regulation with the mutual, but it's safer. And if I was going to stay small, I probably would explore a lot more of that. And we do help. Sedera and Zion are the two that we use. So we have lots of their members that put our primary care in front of it. And instead of using the mutual insurance company, they use Zion or Sedera. Those are two excellent medical cost shares.
Oh, and the follow-up to that, in his question, he's asking, in your model, who is paying the providers, us or you guys?
Oh, we are 100%. Yeah, that's the part I went fast.
Yeah.
Third-party administrator, the TPA licensing. So there's two ways you can pay a doctor in America. The individual can pay it, or a licensed entity called third-party administrator who has fiduciary responsibility to move the money correctly and put things in the right claims accounts. So we have third-party administrator licenses in all 50 states to move the money in and out of our mutual insurance company.
Got it.
Yeah.
Thanks. Now Russell's asking,
the other place with the medical cost share is the medical cost shares. It's much better for a more sophisticated user. If you've got a business and you've got 100 people, I promise you're going to have 40% of our not sophisticated users. So it's not a good solution for a business. It's a great solution quite often for a sophisticated family.
Perfect. Thank you. Next question is, are there age brackets for cost and differences for number of children?
No, remember I said simple? So I kept it really simple. It's $379 there's 4 tiers, $379, no underwriting for an individual, $749 for an individual and spouse, $779 for individual and children, 1 child, 10 children, doesn't matter. $1,099 for entire family, doesn't matter how many children. And we're able to get rid of the underwriting, and the actuaries let us do it for 20 or more employees. So if you're under 20 employees, then we have to have some pre-existing conditions in there, which is for another. It's on our website. You can see it easily.
All right.
Any more?
Other questions?
Yeah, I wrote a couple down here.
Is that Rob?
Yep. One sec. Let's see here. How has I have a family member who is a chiropractor, and he says that like the Affordable Care Act, Obamacare has, dramatically changed the healthcare space. And, if you had invested all your money in healthcare companies since the Affordable Care Act was started, it would have returned better than almost any other asset class.
100% true. You would have returned about United Healthcare was $17. It's now over $400.
It's crazy.
Yeah.
What is there future regulatory risk in this space? For
There always is. Yeah, definitely
model?
there is. And that was the number one reason why we went with the mutual insurance company versus creating our own medical cost share, which we did also. We have a medical cost share piece of it for just the hospitalization for groups under 20.
Yeah.
But the medical cost shares are probably at greatest risk of regulatory. The reason, so we got licensed in our mutual insurance company, so it protects us. So because there's already law in place, we fit in it. The third-party administrator, we have 50 licenses. Trust me, I don't like licensing. The reason I did it was exactly the reason you're saying, is I want to make sure that I wasn't having to go to thousands of clients and go, oh, the model doesn't work anymore because the administration changed something. So we are very, very aware of what is likely to change, what couldn't. And we spent a lot of dollars to stay within the system where it protected the community, the association, but then we do it our own way. Where like nobody regulates how doctors navigate with other doctors.
Mhm.
So that's where we chose to be special.
Okay. Cool.
All right, other questions? Anyone?
So
Okay.
actually, if there are no others, I was going to say, is there kind of an ideal company size for working with your firm? You know, if we have 400 employees, but maybe 100 of them are full timers and
Yeah.
eligible for benefits.
So, I used to like say there was an ideal size. I would say the ideal company for us right now, it always comes down to the same thing. Is there a leader, a CEO that believes their job is strategy? And if they can get everyone in their company with a simple and affordable answer, they believe they can turn it into a competitive recruiting, retention, workers' comp, productivity, core value alignment advantage. Like those are all things that the leader does.
Mhm.
And doesn't mean they don't use their HR folks to communicate the plan and make sure it's being used effectively by the people. And it doesn't mean they don't use their financial person to make sure that the money is there. But it really, I've seen companies with 10 people and the leader says, nope, that's my office manager and broker's job. Well, that's a terrible client fit for us. Like it is really hard. And I've seen up to 2,000 people where the leader is like really embracing this concept of, yeah, I'm the strategic guy in this company. So I've seen that range. But when we deal with entrepreneurial companies, there's quite often that leader plays all three of those roles. So it's a lot easier to get it into a smaller company than a bigger company because there's less layers of bureaucracy, less chance the leader's going to disown the strategy piece.
Mhm. Okay.
And here's we find some companies like let's say banks. We've talked to a few banks where we say, hey, we're not a good fit for you because they don't even perceive they're spending too much money on healthcare. The banking industry does not perceive they're spending too much, and so that it's just not a good fit. Even a small community bank it's the weirdest thing. At the same time, though, I used to think that government and small municipalities and school districts would never be a client of ours, but we've got a couple school districts right now that are. So I'm learning stuff all the time about who an ideal client is, but it always comes down to, is there a leader who's thinking very strategically? And I never did it. For 10 years, I didn't think strategic about my healthcare spend. I just turfed it to a HR manager and a broker. So I get it. I'm not judging. That was me for 10 years.
Mhm.
And I just got sick of it, and then I took it over. You couldn't pry this out of my hands right now as the CEO of my company. There's no way. I could be 100,000 employees, and I'm in charge of healthcare return on investment. I promise you.
Very cool. Thank you.
You're welcome.
Awesome. So let's see here. We got one more question. Grant's asking, will I still get the same treatment if I get sick? How does my experience change?
We still get the same treatment. I hope not, because the treatment people are getting today sucks. Meaning, here's what you won't have to do. You won't have to find a doctor, call a doctor, schedule an appointment, coordinate, take time off work, unless you really have to. So we'll do a lot of that for you. So the way people interact with us is they use the app or they call us. They could always do it on their own. And we've got some really smart incentives in there where it costs a little bit more money if people want to do it on their own. It costs normal dollars if you want to go to the doctor without even letting us know. But if you let us know, it'll be free. So we've created the incentives in the benefit design, which you'll see if you go to my website, where it's $50 to do it on your own. It's $0 if we do it for you, and you'll see the same doctor. But the reason we can do that is because there's a good chance, probably 2/3 of the time, where we'll take care of you right there over the phone, and you won't need to see your doctor. Right. So let's say that you've had some blood work done. It's quite profitable in America with normal insurances that you go back to see your doctor to get the blood test returned, especially if the cholesterol's high or there's something a little abnormal on it. Well, that's 2 visits, 2 times off work, 2 trips to the gas station, perhaps. It's quite possible that both of those could have happened over the phone. We could order the blood test and then report on it over the phone. And if it's bad, then we'll set up the visit right to the specialist and even bypass the primary care. So we're looking for opportunities to bypass brick and mortar and get to the proper parts in the journey, healthcare journey, faster. So the experience should change, but it shouldn't change for the worse. It should change for the better. But there's always, I tell everybody, expect 5% of your employees to really be invested in the traditional way of doing it, the traditional journey. And if you want to take care of everybody in your company, you've got to have a benefit design that takes into account that 5% that don't mind if they spend $180 for a statin when it should be $569. But they might not, they might just not mind for the first 3 months. But then over the next year, they're going to get smarter, and next year smarter, next year smarter. So there's a bit of a long game to it also. You don't have to be perfect. No, I built a lot of systems in my life, and the best ones are the ones that don't need to be perfect. The best ones are the ones where people aren't going to do what you expect them to do, and you have to be able to adapt and adjust on the spot.
Awesome. Awesome. Well, Dave, thank you so much for giving us a peek behind your curtain and how you changed the way you're going about healthcare. It gives us a lot to think about, and certainly I'm sure you've piqued some interest and people start looking into their own plans a little bit. I know I am. But with that, I just want to thank everybody for taking the time to join us today, and Dave for being so generous with yours. If anyone has follow-up questions or wants to explore any more or thoughts, what should they do?
I'll give you my email address. It's david.berg, like iceberg, at redirecthealth.com. Just
Awesome.
email me. Yeah, and then I'll help you with any questions you have. Or our website, redirecthealth.com, is pretty good for seeing the benefit design and what we offer. Also, redirecthealth.com/ending the fight. Ending the fight is right to our landing page to get the book that I wrote, and it'll tell you a little more about just the detail of what we went through today.
Awesome.
Yeah.
All right. All right. With that, everybody, thank you. Have a great afternoon, and we'll see you again soon.
Thanks, guys.
Okay.
Thanks.
Okay. Appreciate you. Thank you. Bye-bye.
Thanks.